Shoulder dystocia is a dreaded complication of vaginal delivery. If it is not managed in time, the fetus may die and there would be an increase in maternal morbidity. One must be well versed with the shoulder dystocia drill. The objectives of this presentation are to learn the prevention, diagnosis, and management of shoulder dystocia, and thus prevention of the perinatal mortality and maternal morbidity. The topic will be discussed under the following headings: definition, risk factors, complications, preliminary steps, primary maneuvers, secondary maneuvers, and summary. Shoulder dystocia is defined as the difficulty in the delivery of fetus shoulders after the delivery of the head. As shown here, the head is delivered, but the shoulders are stuck. Quantitatively, it is defined when the head-to-body delivery time exceeds 1 minute. The dystocia could be due to either the impaction of anterior shoulder behind the symphysis pubis, as shown by the arrow, or it could be due to impaction of posterior shoulder behind the sacral promontory, as shown here. The incidence varies between 0.2 and 2% depending upon the assessment of the operator or the maneuvers used. The dystocia could be unilateral, where only one of the shoulders is stuck and it is rather easier to manage. Or the dystocia could be bilateral, where both the shoulders are stuck, and this variety often requires cephalic replacement, which is usually difficult and fraught with fetal death and increased maternal morbidity. Shoulder dystocia is best managed by prevention, and for that, one must anticipate it in high risk cases. The high risk factors may be antepartum, such as obesity, GDM, excessive weight gain, and post term pregnancy, or they could be intrapartum events such as need for oxytocin augmentation, prolonged second stage of labor, difficult forceps and vacuum extraction. One must remember that in many cases there may not be any identifiable risk factors. The maternal complications of shoulder dystocia include postpartum hemorrhage, vaginal lacerations, cervical tears, and puerperal sepsis. The fetal complications include fractures, brachial plexus injury, for example, Erb's palsy, due to the dragging on the neck, asphyxia, and even death. Let's now go through shoulder dystocia drill. Like in CPR, the first step is to call for help, as this complication cannot be managed alone. One must remain calm and composed, but well prepared to meet the challenge. Like before any procedure in obstetrics, we must empty the bladder, preferably using an indwelling catheter, which may be continued after the delivery also. A generous episiotomy will increase the space for different maneuvers, which will be explained shortly. It's a teamwork, and the individuals that must be around are an experienced obstetrician who will serve as a leader of the team and should be the only one giving orders. Then There should be a neonatologist to resuscitate the possibly asphyxiated baby, anesthesiologist to take care of the epidural if given, or should the need for caesarean delivery arise. Experienced nursing staff and some extra helping hands. There are several maneuvers and they could be grouped as primary and secondary. Following are the primary maneuvers: gentle traction, McRoberts maneuver, suprapubic pressure. In fact, these three maneuvers could be performed in concert for the effective delivery of the baby. If these fail, we have Wood's corkscrew maneuver and delivery of the posterior arm. Let's go through one by one in detail. Gentle traction. Many do not consider it as a special maneuver as this is always performed to deliver even in the normal shoulder delivery. However, this could be tried in minor shoulder dystocia before attempting other maneuvers. Gentle traction includes gentle pressure on the fetal vertex in a dorsal direction as shown by orange arrow. This will move the posterior fetal shoulder deeper into the maternal pelvic hollow as shown by blue arrow, usually resulting in easy delivery of the anterior shoulder as suggested by green arrow. One must remember not to use excessive angulation of the neck to avoid brachial plexus injuries. If gentle traction fails to deliver the shoulders, then McRoberts maneuver may be employed. In fact, this is a simple and commonest maneuver performed. In McRoberts maneuver, the thighs are hyperflexed on maternal abdomen as shown in the picture. This decreases the angle of pelvic inclination, thus improving the direction of maximal expulsive forces. Cephalic rotation of the pelvis also frees the anterior shoulder. McRoberts maneuver may be combined with suprapubic pressure and gentle traction for effective delivery of the shoulders. Let's now look at suprapubic pressure, which is also called Rubin 1 maneuver. The idea of suprapubic pressure is to decrease the bisacromial diameter. It is usually applied in concert with McRoberts maneuver, as told earlier. The pressure is applied just above the symphysis pubis, and it is better applied by an assistant. This is necessary to disimpact the anterior fetal shoulder under the symphysis pubis, and the pressure is directed downwards and laterally in order to effect the rotation of the fetal anterior shoulder under the symphysis pubis, as shown in this picture. When the above three maneuvers fail, one may choose Wood's corkscrew maneuver, which is similar to Lauset's maneuver of assisted breech delivery of nuchal arms. The logic here is when you rotate the arms, the low-lying posterior arm gets delivered first, and then it becomes easier to deliver the other arm. In Wood's corkscrew maneuver, the shoulders are rotated utilizing the pressure on the scapula and clavicle and not by holding the head. When the posterior shoulder is rotated counterclock direction, the anterior shoulder rotates out under the symphysis and delivers. During these maneuvers, expulsive effort should be stopped, and as told before, the head is never grasped. The complication of this maneuver is that fetal clavicular fracture in the direction of apex of the lungs can happen at times. As you can see in the picture, the rotation of the shoulders is done using pressure on the clavicle and scapula and not by holding the head. The pressure on the posterior surface of the anterior shoulder may ease rotation. As you can see, one of the shoulders is already delivered, and then it becomes easier to deliver the other shoulder. Last of the primary maneuvers is delivery of the posterior arm. One may choose to deliver the posterior arm by introducing the hand in posterior sacral bay, which has comparatively more space, as shown by orange arrow. This maneuver is similar to Pinard's maneuver of delivering the extended leg in assisted breech delivery. To bring the fetal wrist within the reach of the hands, one should exert pressure, as shown by blue arrow, on the antecubital junction. In Pinard's maneuver, we exert pressure on the popliteal fossa to bring the ankle in the grasp. If the arm is not already flexed, pressure is applied to the antecubital fossa. And then the arm is held and swept across front of the chest, and delivery is completed as shown here. When all the primary maneuvers fail, one may go for secondary maneuvers, and they include the Rubin 2 maneuver, Chavez maneuver, Gaskin all 4 maneuver, fracture of the clavicle or cleidotomy, and finally Giovanelli maneuver. In Rubin's 2 maneuver, the fetal shoulders are rocked from side to side, and we push the presenting fetal shoulder towards the chest. This will often cause adduction of both the shoulders and create a smaller shoulder to shoulder diameter. Two fingers are pressed against the posterior of the most accessible shoulder. Concomitant fetal elevation makes the maneuver much easier. And finally, one can deliver the anterior shoulder under the symphysis pubis. In Chavez maneuver, a shoulder horn consisting of a concave blade with a narrow handle is slipped between the symphysis and impacted anterior shoulder. It works like a shoe horn, and it is used to lever out the anterior shoulder using the symphysis as fulcrum. In Gaskin's all-4 maneuver, the patient is placed onto her hands and knees. The traction is applied towards the floor, directed towards the delivery of the posterior shoulder first. Fracture of the clavicle is one of the last two options and involves serious injury to the fetus as well as mother. Usually, it is tried in a dead baby. However, it may also be utilized in a live fetus. The anterior clavicle is pressed against the ramex of the pubis. Theoretically, it is less serious than a brachial nerve injury and often heals rapidly. This would reduce the bisacromial diameter, and hence the delivery is possible. Giovanelli maneuver is really the last resort to deliver the fetus. By this time, usually the fetus would have died. However, In order to reduce the morbidity of the mother, this method is utilized. It is mostly for bilateral dystocia where both the shoulders are stuck above the bone, that is symphysis pubis in the front and sacral promontory behind. It consists of cephalic replacement followed by caesarean delivery. It is easier said than done. Fetal death is inevitable, as told before, and maternal morbidity is high. The first step in Zuanelli maneuver is reversing the external rotation and the restitution of the head and bringing the occiput completely anterior as shown in this picture. Then gently the head is flexed and tried to be replaced in the pelvis. Once the head is completely replaced in the pelvis, it is followed by an emergency caesarean delivery. How about symphysiotomy? Once a common practice in the past, it's never an option in modern obstetrics. Which maneuver is better? There is no conclusive evidence to suggest that one maneuver is superior to another. It has to be individualized, and the team may regroup and repeat the maneuvers should one fail. However, the baby should be delivered within 5 minutes of the emergence of head. Else, 47% of the babies may die if you go beyond 5 minutes, according to an RCOG report. In summary, we diagnose shoulder dystocia if there is a delay of more than 1 minute between the head and shoulder delivery. One should anticipate shoulder dystocia in obese patients with macrosomic babies. The preliminary steps include calling for help, catheterization of bladder, and giving liberal episiotomy. The primary maneuvers include gentle traction, wherein you try to disimpact the shoulder under the symphysis pubis. Mike Roberts maneuver, wherein you hyperflex the thighs, and you usually combine this with suprapelvic pressure again to decrease the bisacromial diameter. If that fails, one may go for Wood's corkscrew maneuver, wherein you rotate the shoulders so that the one shoulder delivers easily and then one can deliver the other shoulder. Delivery of the posterior shoulder is a maneuver wherein you put your hand inside the sacral hollow and gently bring out one of the shoulders. When above maneuvers fail, one may try for secondary maneuvers like Rubin 2 maneuver, where you gently rock the shoulders and deliver one of the arms first. In Chavez maneuver, you use a shoehorn type of an instrument and insert it between the anterior shoulder and symphysis pubis and lever out the anterior shoulder. Gaskin all four, you put the patient on her hands and knees and try to deliver the posterior shoulder first. Fracture of the clavicle is not an option in a live fetus. However, in a desperate situation, this could be done. Giovanelli maneuver, the baby would have already died, but in order to decrease the maternal morbidity, one should try to replace the head in the pelvis and go for caesarean section. Maternal and fetal injuries are common during all these maneuvers. The risk of fetal death increases after 5 minutes of the delivery of the head. So one must try to deliver the baby within 5 minutes of emergence of the head. Ending the presentation with a mnemonic called helper, wherein H stands for calling for help, E stands for episiotomy, L for legs curled up, that is McRoberts maneuver, P for pressure, suprapubic pressure, E for enter maneuvers like Wood's corkscrew maneuver, R for removal of the posterior arm first, another R for roll the patient, that is Gaskin all four. Thank you for your attention.